Hey there, David Chesworth coming to you for another episode of Health Talk here at Hilton Head Health on the beautiful Hilton Head Island. And today we're going to talk about anti-obesity medication. I've got the perfect guest for it, Dr. Jamy Ard. Dr. Ard is a clinical researcher focused on studying strategies to treat obesity in adults. He is the co-director of the Wake Forest Baptist Health Weight Management Center, where he oversees the medical weight management programs. He has a particular interest in working with specific populations of adults who either suffer from obesity disparities or where obesity treatment is particularly challenging. And his team is also conducting research to explore how to use new obesity treatments to control or bring about the resolution of chronic diseases such as type 2 diabetes. So, Dr. Ard, thank you so much for joining us today. It's great to have you here.
Glad to be with you, David.
Yeah. So I was talking to, I know we met several years back. We were actually just talking before the episode. You and your team came down here to Hilton Head Health, and you got to see our program and learn it. We got to learn about what you do, and it's really cool to connect in this way. It seems over the past several years, anti-obesity medications have just really gone up in awareness, and we hear a lot more about them at our facility. And I was actually just talking to Bob yesterday. I was asking him, I was telling him I was going to talk to you, and he said, be sure to refer to it as anti-obesity medication, because last time I talked to him, I said weight loss medication, and he corrected me.
Yeah, it's you're right. I mean, everybody's talking about the revolution that's happening with the newest, sort of generation of highly effective anti-obesity medication. And as I was explaining to Bob, what we're doing is talking about treating chronic disease, the disease of obesity. And if it were just about weight loss, we tell people, the job is done once you've reached your goal weight, and they're no longer necessary. Medication is no longer necessary after that. And so I'm sure we'll get into all of those specifics, but yeah, it's it's amazing how much things have changed in terms of the conversation and the interest that people have in treatment these days.
Yeah, for a long time, well, I don't know how long, honestly, but it seemed like for a while there was a little bit of taboo around it. At least that's how it felt at our facility, where we may have had guests who were on them, but maybe felt a little ashamed that they are on them and or didn't really want to talk about it. But now our guests are a lot more open about it, and I think that's been an interesting change to see as well. Yeah. So I guess my first question for you, Dr. Ard, is, are anti-obesity medications, are they the magic bullet that people have been looking for in terms of their weight management?
Well, I'll go back a little bit, because I think that a lot of the new interests that people have in this space is really about and centered on the newer GLP-1 based treatments. And those treatments are definitely leading to, sort of average weight loss effects that are greater than what we've seen in the previous generations of medications. But there are a lot of similarities in terms of how we approach use of these medications, and the concept of how they really sort of fold into the overall treatment strategy. So are they a magic bullet? No, they're not a magic bullet. There are some people that don't get the expected treatment response. There's some people that have side effects with these treatments, as people have talked about. And for all of the medications that we use, we will see that people have to continue to do certain things in order to get the best treatment response possible. And that means that people will continue to have to be physically active, right? The medication doesn't make it so that you want to exercise, but it makes it easier for you to exercise with less pain, right? If you're starting out at a much heavier weight, you start losing some weight, you feel better about that. You have less pain when you go out and walk, or you feel less discomfort with that. So that's reinforcing. So that's helpful, but you still have to make the choice to put the shoes on and make the time to go out and take that walk, right? So taking that semaglutide doesn't give you that, sense of like, yeah, I just got to go walk now. it requires that you still continue to eat a healthy diet, right? That's a central
Mhm.
part of trying to achieve the healthfulness that we're hoping that patients can achieve is achieving a healthful diet. And yeah, the medications can make it easier to make choices that are more helpful, right? You have less temptation, you feel less craving. People talk about the idea of food noise, those types of things, right? So that is improved. And so it makes it easier for you to make that better choice, but you still have to engage on that aspect of your eating plan. And then you still have to take care of yourself and do all the other things that are part of a healthful lifestyle. So, magic bullet, no, but significant improvement in efficacy and the effect and the impact on how people respond to the food environment and so forth. Yeah, yeah, they are doing that, and the newest medications have definitely changed that in a way that is broader and more effective for a lot of people.
That makes a lot of sense. So it sounds like really it's a really strong tool in the toolbox for a lot of people on their weight management quest or anti-obesity pathway. And so I like how you were describing that. It what it does do is it maybe helps you navigate the food environment better, but you still have to make the choice to navigate the food environment. So I'm wondering if you can elaborate on what is the mechanism? How exactly do the medications work? What specifically do they do, and why does it make it easier then to make those choices?
Yeah, so let's be specific in what we're talking about. So right now we're going to focus on the GLP-1 based treatment. So this includes semaglutide and tirzepatide. There
Okay.
are any number of other medications that we still use. So what we call first and second generation anti-obesity medications, or AOMs, we'll use that abbreviation to make it a little bit shorter. Those AOMs all work in different ways, but the GLP-1 based treatments have a couple of different things that they do. So one, they slow down emptying of the stomach. So people tend to feel a little sense of fullness longer and maybe even earlier. Okay. Um, there's some debate about how important that peripheral or that stomach related slowing of food emptying is in the medical community, but I tend to think that for some people it's very important. And the fact that the contents of the stomach don't empty as quickly means that yeah, you might feel full longer between meals. Okay, so that decreases what I call unplanned snacking. Right, so
Mm-hmm.
snacking is fine, but when it happens in a sort of unplanned, arbitrary way, where you're just passing by the pantry and something catches your eye and you decide, oh, I'll take a handful of that. Right, that tends to go down. Um, the other thing that happens, though, where the real action is, where the money is in the brain. We have receptors in the brain that um, are triggered by GLP-1. This is a molecule that these drugs mimic. We naturally make GLP-1 in our body, but it gets degraded pretty quickly, and it's around when we eat, but then it goes away pretty quickly. And so these medications sort of mimic that GLP-1 molecule, and it stays around for about a week at a time. So it helps to activate areas in the brain that we know are related to appetite control, so that you feel less hunger and you tend to think about food less. So those are two key effects that when you decide yeah, I'm just not as interested in food. And when I eat food, I feel full earlier and I am um, less hungry overall. Um, what ends up happening is that your brain starts to allow you to decrease the total amount of food that you eat. And for those individuals who are at a higher weight than what they need to be, they start to lose weight as a result of that reduction in total food intake. And that's how these medications generally work, is you ultimately get a reduction in total food intake through those two different sort of mechanisms. And that leads to a loss of fat mass, ideally, um, and a lower body weight.
So that's fascinating. So really, it works on a physical and a chemical from both sides. Like it slows down digestion, which, as you pointed out, may or may not fully have an impact, but probably it does. It sounds almost like a medically promoted version of mindful eating. You're kind of prompted to eat slower and probably be satisfied for longer as a result. But it slows your digestion down, and then the chemical temptations that you have in your brain that trigger food cravings almost get numbed down. Is that a fair way of recapping what you said, or is
Yeah,
that a little bit off?
I think some of that is fair to sort of reframe it that way, or cap it that way. Um, I think that one thing that these medications have really sort of helped people understand is that everybody's response to the food environment is different.
Hmm.
And I use this analogy all the time of, you know, I might go to the doctor or the dentist and get a short-term prescription for a pain medication that might contain opioids. And it does nothing for me, right? It helps
Hmm.
with my pain, but I don't feel a high. I don't have any sense that, oh, this is, something I need to that I crave or that I want to have again. I might even feel nauseous as a result of taking the medication, and I want to take as little as possible. Other people can take the same medication and immediately know, oh, this is a problem for me.
Hmm.
And it lights up their brain in a very different way. Um, the same can be true for alcohol. The same can be true for any other substance, chemical substance that we might ingest. And food is really not very different, in that it elicits a number of different responses in the brain, not only from the sort of energy sensing and understanding, like a sense of hunger and fullness, and how much energy we might of our energy needs are met, but also reward and pleasure and all these other centers in the brain are activated as a result of the types of foods that we eat. So one Oreo for me may, be a problem because I know I'm going to eat the entire sleeve if I have one. Whereas you might say, yeah, I have an Oreo once a year and I'll never think about Oreos again. Um, and so I think that's the additional sort of layer I would put on, how you talked about,
Hmm.
yeah, there's a mindfulness component and there's other sort of things that have a behavioral overlay. But then there is, like you just said, like there's a chemical difference in terms of how one person's brain responds to the environment versus another person's brain. And these medications help to, if you will, level that playing field so that someone who might,
Hmm.
be really affected by that Oreo has the take it or leave it approach that you or I might have to that, trigger, that stimulus. And so then, for a lot of my patients, they will say, I've never felt that way about food X, right? Like I've
Hmm.
never been in a situation where I could have, be in a room where there's cake and not feel compelled to eat it. And
That's
for
amazing.
me, yeah, that's a very different feeling that some people have never been able to realize until now.
Wow, that is pretty powerful, actually. I mean, we interact with a similar clientele, and just kind of hearing that, a lot of guests would say, "Man, I would dream not to have that temptation be so strong, or to just be indifferent about a food item that they haven't been ever been indifferent about." So that's
Yeah.
pretty amazing. Um, Earlier, you mentioned that a couple of things. You mentioned that some people experience different side effects. You also mentioned that different people react to to these medications differently. There's one guest who came to our facility that stands out in particular, who said she tried it and the side effects were just too much for her and it wasn't worth it. I think for her it was a digestive issue, but I'm curious what types of side effects you have seen, and is it an all or nothing thing, or are there different medications for different types of people, or is that? I'm curious what your thoughts are around that.
Yeah, so if we start with the GLP-1 based treatments, the most common side effects are GI related, so stomach and gut related, and that's going to be nausea, vomiting. Most people will feel something in that, range. Not everybody will vomit. A lot of people will feel nausea. Maybe 8 out of 10 people might feel some sense of nausea. Constipation or diarrhea will definitely be in play for some people, both of which can be managed based on how you manage your dietary intake, maybe using some supplementation of fiber and that type of thing. The nausea tends to go away or decrease over time. So there's a slow adjustment and titration of medication to get to the right dose that's effective but doesn't cause side effects. Some people will definitely, maybe like that client you talked about who, was unable to tolerate it. That, some people's sense of nausea or vomiting will be really strong with even the lowest dose of medication in the GLP-1 category. So they can't take one of these sort of once weekly types of treatment with GLP-1. But there's a daily GLP-1 based treatment, liraglutide, and that can be effective for people, especially that are very sensitive to a weekly dose. We have other medications that we use that combine, say, phentermine with topiramate. Those medications will tend to have more psychoactive side effects. So some people might feel a little bit jittery, or will notice that they have an extra, sort of boost of energy when they first start taking it. Some people like that because it helps them, get the garage clean over the weekend, whereas otherwise, it's just been on the to-do list for forever. But, dry mouth constipation can be a part of that side effect profile with that type of medication. So each of the medications that we have access to will have a slightly different profile, and depending on other health-related conditions, if someone has high blood pressure, or if they have type 2 diabetes, or if they've got some other GI-related issues like reflux or whatnot, we may choose one medication over another when we're thinking about the overall sort of strategy of how to maximize benefits but minimize potential risk or side effects.
So it sounds like it's a combination of finding the right type of medication, the right dosage, and then for some people, mitigating those side effects could come from the nutrition aspect, whether through diet or supplements, or probably a combination, getting that fiber in. Yeah.
Yeah, absolutely.
And then what about, I hear a lot about those who are on medications are more prone to losing muscle mass. I was wondering if you could speak to that.
Yeah, so one of the things that we're really trying to figure out is, with the latest generation of GLP-1 medications that are leading to a larger volume of weight loss, are people losing a higher proportion of the weight that they're losing as muscle mass, as skeletal muscle, compared to fat mass. And so the general ratio that I tell my patients I'm looking for is, for every pound of weight that you lose, I want at least 80% of that to be fat mass, and minimize the skeletal muscle or lean mass loss to 20% or less. We don't have a strategy that completely avoids the loss of lean mass during weight reduction. We have ways to minimize that, things that I'm sure you promote every day, with things like physical activity, exercise, especially resistance training, getting a good protein source and amount in the diet. Those are, some of the cornerstones of really trying to help to minimize the loss of lean mass during active weight loss. But there are questions with the GLP-1 based treatments that lead to a larger volume of weight loss. Is that proportion of weight loss actually coming from the muscle compartment? is that higher than what we would normally expect? And there's some early data that suggests maybe it is. And we need to have more evidence, more data to understand, is that an inherent property of the medication? Is that a function of the amount of weight that people are losing? Or is it a function of the fact that people are eating so much less that they're just not getting, say, for example, enough protein? And you can then, counsel people to say, yeah, you need to really prioritize protein in your dietary plan when you're taking this medication, and that helps to mitigate that risk.
That makes a lot of sense. Because even with the lifestyle approach, it's very rare that people don't lose any muscle mass on a weight loss plan. And so that it sounds like there's still more research to be done to find out if it's just a function of them losing weight or if the drug is adding to it.
Right. And I'll even say, there are research programs and new medications being developed that look at, can we actually combine something like semaglutide with an additional medication that actually targets muscle growth. So you could actually have something that
like a steroid.
It's not a steroid, but definitely that would have the effect of increasing muscle mass. You're not going to see, we're not going to turn people into bodybuilders, but this is something that we never see clinically with a lifestyle treatment or with a medication strategy, is that people will actually increase in lean mass during active weight loss, right? You just don't see that because you're in negative energy balance. And so you're doing everything you can. Your brain is doing everything it can to hold on to what you have, and you don't have any energy to put into building new tissue. So the best you get is, you get some better definition, you get better tone, but that total amount of lean mass that you have absolutely tends to go down. But with some of these new experimental medications that target lean mass, you can actually see evidence, at least in some early clinical trials, that people do increase their lean mass by 1 or 2 kilos, which is important when you think about energy expenditure and strength and physical function, all of those types of things.
So I'm curious, are there, with the clients that you work with or the patients that you work with, are there situations where weight loss medications are more appropriate than others? Are there ever people that you see where you would not recommend them? When would you recommend them, and when wouldn't you recommend them?
Yeah, so there are definitely situations where we would say, it's not appropriate for use of an anti-obesity medication. And that includes things like, starting with some very basic things like, okay, well, someone who doesn't meet the criteria in terms of the starting BMI, body mass index, right? If you don't have a body mass index of 27 and higher, with a complication, or 30 or higher, even without a complication, then generally we're not recommending, medication is not indicated. Also, we look for and think about, what are we actually treating when we're, trying to think of a medication strategy, and what are the longer term implications, the short term and longer term implications for making a particular choice. And then also we think about, what are the health consequences that a person has now or might develop if we sort of consider this treatment strategy. So, for example, I've had patients who have a health issue called gastroparesis. So it means that they have a slow digestive system. It takes a long time for food to pass through the digestive tract, and they get a lot of issues with the retention of food in the stomach, that type of thing. So when I have those patients and they are considering a GLP-1 based treatment, then I will have to say, look, I don't know that that's in your best interest, because this is only going to make that worse, right? And so that's probably not the best treatment strategy. There are other things that we could consider. So I think those are the kinds of considerations that we'll take into account when we're thinking about is an anti-obesity medication, an AOM, is it appropriate for this patient or not? And then think about, how do we make an adjustment in terms of choosing when it might be.
Mm-hmm. That would make a lot of sense. If they already have an issue with slow digestion and one of the side effects is a slower digestion,
Right.
makes a lot of sense. And earlier, I think you alluded to, this is not just hitting a number on a scale and saying we're done. This is something that, it's a long-term thing. Is that implying that someone who's on them would have to take them forever to maintain, or is there like a weaning off and transition to lifestyle, or does it depend on the person? I'm wondering if you could speak to that.
Yeah. So the best evidence we have right now suggests that on average, most people who start on a medication will likely need it long term. And that evidence comes from the trials that are done during the development and approval process for these medications, where the typical study is you start somebody on a medication, get them to the top dose, which usually takes about 20 to 24 weeks. And then you randomly assign some people to continue on the medication and then some people to continue on placebo and effectively discontinue the medication. And what we see is that people who continue on the medication on average continue to lose weight. And those who are assigned to placebo or discontinue, they tend to on average regain about 60 to 70% of the weight that they lost in the first 20 to 24 weeks. There are some people, we don't know why, we don't know who they are in terms of being able to say, oh, it's this type of person, but there are some people who do continue to lose weight after being withdrawn from the medication. And that's about 20% of the study population, where you see either they maintain their weight loss or they continue to lose weight. And they may have a different type of disease, right? They may not have had obesity as long. Maybe they didn't have as much to lose. Maybe they're younger. Maybe they live in neighborhoods that are more protective or health promoting. There could be any number of different reasons why we see a difference after people are taken off medication. And some of those reasons may be why some people respond to the treatment in the first place versus others don't. So what we practically recommend to people is you can expect that if it works for you in the short term, it's likely going to be useful in the long term. If you are intent that, hey, I want to try not being on the medication for whatever reason, then that's up to you. That's reasonable. And we want to continue to support you during that process. And there's a process to titrate down, look at how your symptoms respond. If you were a person that thought about food all the time, and as soon as you stop or start decreasing the dose, you start to think about food a lot more, then that's probably a sign that you might need that longer term. But if that doesn't bother you, if that was never a symptom for you, then you may be in that category that you could come off the medication and use it in a very different way to help with maintenance rather than having to be on it continuously.
Gotcha. So it sounds like the evidence points towards most people seems wise to continue, but it ultimately depends on the individual circumstance and if they want to continue or not.
Yeah. And the fact is, in our healthcare environment, there are a lot of people who are forced to discontinue because they lose coverage. They go from having private commercial insurance to being on Medicare. Medicare doesn't cover AOMs, or they have side effects that they can't tolerate. So they find that the medication was really helpful, but they can't, continue to tolerate side effect X. And so they need to stop. And so there are any number of different scenarios where we do need to come up with treatment strategies, maintenance strategies that allow people to still feel successful and be successful in maintaining weight loss that was achieved when they were on the AOM.
That makes sense. So I just was reflecting on earlier, you said if they had a BMI over 27 with a complication or a BMI over 30, regardless of a complication. Do you ever have an individual where you consider a percent body fat or muscle mass if you might think that they might have a higher amount of muscle mass. Does that ever come up in your practice, or is that not really the type of person you might see?
Yeah, I would say that's not often the type of person that our typical type of patient is someone who might have a higher lean mass and maybe their BMI is elevated, but their percent body fat is lower. There are several patients in my sort of mind that come to mind, that I've treated over time that do fit that sort of profile where they have an athletic background. Maybe they were a bodybuilder, weightlifter, competitive, or wrestler, football player in their younger frame, and so they've retained a lot of muscle mass, but they still have a slightly higher BMI, or maybe their fitness level is really good, but they've got still carrying some excess weight.
Mm-hmm.
So in those situations, though, we do try to tailor your treatment strategy and sort of think about, okay, what are our functional goals? What are our fitness goals?
Mm-hmm.
What's the body composition that they might be aiming for, the physique that they might be aiming for, and try to think about the right approach and strategy based on those targets.
I'm wondering also early on you had talked about the difference between weight loss and anti-obesity.
Mm.
Um, have you? It seems like there's kind of a little bit of a conversation around people considering them who don't really have obesity but would like to lose some weight. Do you ever have patients that fit that category that inquire about it, and you have to explain to them? Or I'm curious about that.
Yeah, we don't have that as much in our program, and I think that's largely because of how our program is positioned. We're in an academic medical center. People see us as a kind of a tertiary, really specialized type of program, for better or worse. And a lot of times, I think people who are interested in a small amount of weight loss, who don't really have the disease of obesity, I think they get filtered by the primary care provider
That makes
in
sense.
a lot of ways. So the primary care provider is dealing with those kinds of conversations often. We require a fair amount of our patients in terms of providing that upfront information and evaluation, and people start to understand like the seriousness of what we're doing and the complexity of what we're doing. And I think most people probably sort of look at, okay, the intensity of what could be provided and the outcome that I want. If I'm just trying to tone up to get ready for beach season, is it really worth the sort of um, arsenal that the weight management team is going to bring to the table here? And most people kind of make, I think, that decision independently, without us having to coach them to say
Yeah.
maybe you go a different route, and especially if they don't have any real medical health related goals, then they start to realize this what we provide is um, tuned a little differently.
Yeah. Probably a little overkill for them.
Yeah, it'd be like someone, coming to Hilton Head Health and saying, yeah, I got a couple pounds to lose and I'm going to, stay for a month. I mean,
Yeah. Yeah.
they probably get a great vacation and so
Exactly.
forth, but you would probably say, you might be able to do that in your own
Yeah.
space.
You probably don't need us to do that. Yeah.
Right, exactly.
Absolutely. So, for anyone listening out there who is considering them as an option, but hasn't yet pursued that path, what words of wisdom would you give someone in that category?
Well, I would say first start off by trying to identify a qualified health professional that can help you in that decision making process. It should be a shared decision making process. It should be someone who can inform you about the things that we've talked about today in terms of one, how to identify treatments that may be appropriate. What are those side effects? What are the potential benefits? How does that match up with the symptomology that you might have? And what are your health goals? And how do they think that treatment strategy fits into your overall objectives for your health goals? So being able to identify someone who can really kind of coach you through that is, I think, a good first step. Certainly there's a lot of information on the internet, and being able to identify where, you know, they're credible sources
Hmm.
to get that information, because you know, it ranges in terms of quality.
Sure. Do you
Um,
recommend any particular resources to look at?
yeah, so I'm a big fan of the Obesity Action Coalition, OAC. It's a patient advocacy group that really focuses on really helping to bring forward to the patients living with obesity good evidence-based treatments, and helps to create environments that are um, forward thinking in terms of advocacy for patients living with obesity getting access to treatment, and making sure that that access is to evidence-based treatment. So I think they have a great website, and they provide a lot of really, validated recommendations for how patients can go about advocating for themselves and identifying good treatment options.
Awesome. So is there like a resource on there that points them to physicians or?
Yeah, they've got links to be able to look up physicians in a given area. They also have resources that help to summarize, current treatments, and ways that you can, initiate the conversation with your healthcare provider about treatment.
Very cool. So the Obesity Action Coalition, check out their website.
Yep,
Um, find the right professional to talk to see if it's the right thing for you.
absolutely.
So, so curious. Here at Hilton Head Health, obviously, we're more on the lifestyle end of things. We try to stay as informed as possible. But since this is your world, we're curious. What's in the pipeline with anti-obesity medicine? What do you see coming in the future? Uh, what is there to look forward to there?
Well, I think we're going to see a few, sort of interesting developments over the next, let's say, 5 years or so. Um, I think we will very soon start to see medications that are even more effective than semaglutide and tirzepatide, because they combine different um, mechanisms of action with the GLP-1 component. So there are medications that target other receptors combined with the GLP-1 activity. And I think we'll start to see medications that literally are comparable in terms of their effectiveness to bariatric surgery.
Wow.
And so yeah, that's absolutely a wow, right? I mean, when you're
Yeah.
talking about, you might have on one hand the option to do bariatric surgery, on the other hand, you might be able to take a medication once a week that will get you a similar result. I think that's really impactful. I think we'll see medications that are dosed maybe once a month. Um, and so you'll go from, something that potentially you might take every day to once a week, to now options that only need to be taken once monthly. We talked about earlier medication combinations that target muscle mass while you're losing weight. So you increase muscle mass while you're losing weight, and the impact that that will have on metabolic health looks really interesting. Uh, and we're already seeing this, but we'll see more of it, where medications in this space are going to be associated with reductions in cardiovascular outcomes. So fewer heart attacks, fewer hospitalizations for heart failure, those types of things. We'll see resolution of fatty liver. We'll see improvement in sleep apnea. We're already seeing those types of outcomes. So I think we're going to continue to see demonstration of the benefits in that space as well.
Wow. And that's in addition to the benefit that sleep and heart health have as from weight loss alone, there would be additional benefits.
Right, that's correct.
Wow. That's exciting. Well, so this is all being studied currently, so this is not yet public and more needs to be learned. Is that kind of the stage that all of those examples are in?
No, a lot of those examples are already published, and
No.
so for example, semaglutide Wegovy does have an indication now for secondary prevention of heart disease. So if someone has a known history of heart attack or stroke, being on Wegovy reduces their risk of a second heart attack or stroke by 20%. That's been shown in the SELECT trial, and now is part of the indication or a reason why you would use that medication. Sleep apnea data recently published, heart failure data published last year. So a lot of those data are already coming out, and I think what we're going to see is that the newer medications that are in the pipeline will also start to have similar type of results, and then we'll just we'll have a larger toolbox, right? And we'll also be able to hopefully better tailor the treatment to a broader range of people, so that it's not a one size fits all, or two medicines that, or a small number of medicines that we can use. It's a good array of medicines, and we have a better sense of which medicine works for which person.
That makes sense. Well, I guess I have one final question for you. Coming from the lifestyle side of things,
Yeah.
Have you ever seen scenarios where the weight loss the anti-obesity medications should be standalone, or is it always the recommendation to complement it with lifestyle?
Yeah, it's always the recommendation to complement with lifestyle. The guidelines are use of the anti-obesity medication in conjunction with a good lifestyle treatment strategy. I think the intensity of that lifestyle treatment strategy is what we are currently trying to understand, like what's really necessary and what's most appropriate for patients. Some patients still need really intensive lifestyle treatment to go along with their medication. But some people with the use of the medications will need less intensive lifestyle treatment. Maybe they now focus more on their, sort of physical activity component, because one of the things that I think has really shifted as we are, seeing more and more people respond to medical therapy, and we're seeing a broader engagement on that, is we're starting to realize, like, you don't have to use the behavioral tools just to drive the reduction in food intake, right? The medication is sort of helping you do that. And now that frees your brain up to be able to focus in on these other things, right? So it's like when, let's use an exercise. I'm going to use a crude exercise example. You can correct me if I'm wrong, but it's like, having someone spot you allows you to be able to focus on your form without worrying about, okay, this is about to, the strain of the weight is about to, make me topple over or crumple over, right? But, or the strain of the weight makes, puts it, a strain on my form. Now, if I got a spotter, I can focus on my form and make sure that that's right. And then over time, I get better with that, right? So I think the same way, using these treatment strategies, these medications, it frees up some space in people's brain. And so they don't have to count between bites. They don't have to put their fork down every time that, between bites. They naturally will find that they reduce the portions. And so it doesn't matter how big the plate is, right? They can use a big plate and put a small amount on it and still feel satisfied. All the little behavioral tricks that we teach people that help them, sort of adjust to trying to consume a lower amount of food, a reduced amount of food, right? Like, those things are happening naturally now. And so that's the exciting part, I think, is that it gives us a little bit more opportunity to work on some of these other things that have, frankly, just been hard for our patients to do. A lot of that mental gymnastics. This is making that a lot easier.
I love that analogy. Of course, that resonates with me.
Of course.
Background being in fitness. I just imagine it as the ultimate behavioral nutrition spotter. It takes a lot of the worries away. Like you said, you don't have that overwhelming thought of, this could crush my skull. You can just focus on the form.
Yeah.
That's great.
Yeah.
That's great. And if you have that fear, you might not even try. So
Exactly.
having a spotter gives you the comfort to try, which is
Yeah.
I love that analogy. I'm going to start using that.
All right. Good deal.
Very cool. Well, Dr. Ard, do you have any final thoughts or messages you'd like to share with our listeners today?
Well, I think I'll circle back to your first, question, which is, is this a magic bullet? And just reinforce that for a lot of patients, and I know you guys talk about this all the time, is losing weight is a really important part of what our patients want to accomplish, but it doesn't fix your life, right? And being on a medication may make it easier for you to lose weight, but it doesn't fix your life, and you still have to do the work in order to work on your mental health, your self-care, your relationships. This doesn't change the fact that those things, still need to be done.
Mm-hmm.
And so, yeah, it's a hopeful time. And if you need treatment, totally, go out, advocate for yourself, talk to your healthcare professional to do that. But also realize that, a good healthcare professional who's going to help you in that journey may also point out that, yeah, okay, you still have anxiety, right? Or you still have some unresolved issues with that relationship, or you're in a miserable job, and those things aren't just going to change just because you lose weight. A lot of our patients think, yeah, this is the thing that's going to fix everything for me, and they pin their hopes on that. And I think part of that question of is it a magic bullet is even more applicable these days, as people are seeing the impact that these meds are having, but not realizing, like, yep, that doesn't solve everything.
I love that. Well, Dr. Jamy Ard, thank you so much for taking the time to talk to us today. I think you answered a lot of questions, not only for our guests at our facility and our listeners, but also informed me quite a lot on the area, and it's fascinating. I'd love to bring you back on sometime to talk a little bit more.
Great to be with you, David. Always fun to talk and hear what you guys are doing at Hilton Head Health. I think it's such a wonderful program, and I am, a big fan, and thank you for having me on. I appreciate the opportunity.
All right. Thanks, Jamie. And thank you, everyone, for listening today. Hope you got a lot of value out of that. I know I learned a lot about anti-obesity medications. It's a hot topic right now. And as always, remember, these episodes are for you. So comment, send us a message, let us know what you thought of this episode. Let me know if you have any other questions for Dr. Ard. And also let me know, who else would you like to hear us talk to? What other topics would you like to hear us talk about? And as always, thank you for joining us. We'll see you next time.